Go.
Hi, Vito. My name is Nina. How are you doing today? He's probably going to nod, shake his head. We are here today because your physician wants to know if you can wear a speaking valve. And this is a speaking valve, and what the speaking valve will do is we'll place it on your tracheostomy tube, which will then allow air to flow back through your mouth and nose so that you will be able to have a voice. So I'm going to talk to you a little bit about the steps that we're going to take in order to successfully place this valve, but you have to wake up first. His eyes are closed. He's asleep.
Oh my God.
Okay. I don't know why his eyes are closed. He's supposed to be awake. Your patient would be awake and responding. Okay, don't ignore his fact his eyes are closed. Okay. So the steps we're going to take is initially we are going to deflate the cuff on your tracheostomy tube, and when I do this, it's going to make you start to feel air flow through your throat, and it can be a little uncomfortable at first, but it's completely safe, and we'll go really slowly, and if you need me to stop and reinflate, we will. After we deflate your cuff, then you will then be able to inhale through your trachea here at the level of your tracheostomy tube as well as to your mouth and nose, and you can exhale as well, that there'll be some air escaping through your mouth and nose. But it won't be enough for you to be able to talk. So that's when we will use this valve that I showed you, and when I place the valve on, you will be able to inhale through your trachea but exhale through your mouth and nose. And we are going to make sure that you have plenty of room to exhale around the tracheostomy tube by doing some occlusion jobs. Okay? Okay, here we go. You would have gloves on. I don't have gloves on. But you have gloves on. So here we go, Vito. I'm going to slowly deflate your cuff. Good. How you feeling? Oh, you sound like you have some secretions. We're going to ask our respiratory therapist to suction you when you get this cuff deflated. Okay, you're probably going to hear him cough. He might just start talking. He might be freaking out, and you can't handle it. So you would deflate this cuff very slowly. You sound like you've got quite a bit of mucus in your upper airways, so I'm going to go ahead and ask the respiratory therapist or your nurse to suction you. So then if you hear a bunch of mucus, it's wet, gurgly, there's lots of yucky, slimy stuff coming out the trach, you're going to want to clear that out, because if there's excessive amounts of mucus here, then the person will not be able to tolerate the valve because the mucus will block airflow. So, oh, he's coughing, he's sputtering, they're suctioning him. You give him time to relax. Okay, you sound much better. And he's shaking his head at you because he can't talk. All right, so Vito, what we're going to do is we're going to see if you can move air around that trach and be able to exhale air through your mouth and nose, and as well as turn on your voice. Are you ready for that? Great. Okay, so on the count of 3, I'm going to ask you to take a deep breath in. I'm going to put my finger over your tracheostomy tube, and I want you to just blow gently out your mouth and nose. Are you ready? Okay, on the count of 3, inhale. 1, 2, 3, inhale. And blow. Oh, good, I felt air. That's great. If you did not feel air, not great. Let's try that again and see if you can turn on your voice. Are you ready? So on the count of 3, you're going to take a deep breath, inhale, and you're going to go, ah, and let's see if we can hear your voice. Are you ready? Okay, deep breath in on 3. 1, 2, 3. Ah, beautiful. You got a great voice, Vito. Okay, so next we're going to actually put your valve on so that rather than my finger being over your tracheostomy tube, you're actually going to have this speaking valve. And remember, you will be able to inhale through your tracheostomy tube, exhale through your mouth and nose. Are you ready? Take a deep breath in. On 3, I'll put the valve. 1, 2, 3, inhale. Beautiful. How you doing today, Vito? I'm doing great. Where's my lawyer? I want to sue that blankety blank blank hit me. So all right, so then he has his valve on in place. Sometimes they don't tolerate it for very long because it does change the way that they have effort when they're able to now exhale all the way out their mouth and nose. So sometimes they only tolerate it for a couple of minutes. You have to take it off, give them a break. If they start what's called stacking of air, meaning they truly don't have enough room to exhale, the valve will pop off, or you'll start seeing them having some difficult work of breathing and you'll need to take the valve off. So if we got to the point, Vito, I'm going to take it off, okay? 1, 2, 3, here goes. If you go to take it off and it's like a poof, it means they're stacking and it's probably need to look out why. But they'll tell you that they can't tolerate it if that happens. So if when you deflate the cuff and you go to do the finger occlusions, there's no voice, there's no airflow, it means they do not have a patent upper airway. Something is obstructing the airway. It can be that the tracheostomy tube is too large, and you look to see what size the tracheostomy tube is by looking on the side over here. I would ask you not to do this because you're going to get a big loogie slapped right in your face when they cough. A big honking piece of snot out of their trach hits you right in the forehead. So when you're working with trachs, you typically stand to the side because it's pretty gross when you get hit. But you can look, and I would probably go around the side of the bed instead of put my head, and you can see here that this is a size 6. Okay. All right, so that is pretty much so how you do the assessment. You will be expected to be able to inflate and deflate the cuff. Okay, so you need to show me that you can inflate and deflate the cuff. You'll need to show me that you can explain the process to the patient, that you can explain to him that what you're going to do, why you're going to do it, what it's going to feel like. Show me that you can do some finger occlusions, and show me that you can safely don the valve. If you don the valve with the cuff inflated, you fail because you've killed your patient. Okay, you need to practice making sure you understand the steps. Introduce yourself, explain the procedure, explain how the valve works, explain the steps to the patient, and then perform the steps. Okay, remembering that when you're in the sim lab, you'll have vital sign monitor. You'll be able to monitor their oxygen saturations, you'll be able to monitor their heart rate and their respiratory rate on a monitor. It's going to be like in a hospital bed with the monitor above. We can start playing, and the high fidelity mannequins talk to you, turn blue, throw up, answer yes, no questions. They do all kinds of things. They don't actually throw up, they just make the sounds like they're going to throw up. So if you look at this patient when you walk to the bedside and the oxygen saturation levels are at 88, you don't do anything. The oxygen saturation levels have to be 94 or greater for you to be even able to try this, okay? So if the heart rate in your person starts to skyrocket, like, you know, just go high, like you'll see it, it'll start at a normal rate probably. If their heart rate is off the chart, it means they're freaking out and they can't handle it. So make sure their heart rate's not racing, that their respiratory rate is not racing, okay? But if they look pretty normal and calm and awake and alert, you introduce yourself and they're interacting with you gesturally, then you can kind of move forward and go through the process. So you're gonna have to inflate and deflate a cuff, safely don the valve, and you're going to also have to show me that you know how to put, remove the inner cannula. You're going to have to show me that you know how to remove the inner cannula and also replace the tracheostomy tube, okay? So, those were on the list, right? Were those on the list? Or is it just don and don the valve? I want you guys to practice putting the tube in. So here is the inner cannula. It's got little clips. So when you are removing an inner cannula, you hold the flange, press the clips, and you just pull it out. Okay? So you hold the flange just to give it some stability. When you go to put it in, if it's just the inner cannula, that you can just put straight in and clip it on so it doesn't come out. Okay? So you hold the flange, release the clips, pull straight out, and it comes out. Okay? Putting it in, hold the flange. You can go straight in. You may have to wiggle it a little bit if it's not. Most humans are pretty slippery, so it slips right in. Mannequins are not. Okay, so that's how you put it in, and then you would inflate and deflate the cuff. So right now it's deflated. To inflate it, you fill your syringe with air. You attach it, twist it on, push the air into the pilot balloon, which then inflates the cuff inside the trachea. Typically what happens when you are working with a live patient is you don't want to overinflate that cuff, because if you overinflate it, then you're going to be rubbing the inside the trachea, right? So you have to have a set of hands, but you listen with a stethoscope until you stop hearing air flow at this level, and then you just pull back by about a half an ml of air. And you can see the mLs are marked on here. This is a 5 ml syringe. I typically use 10 because it's a little easier to work with. This is a little bitty one. Not sure where all my syringes went, but so putting air in, you fill the syringe with air, push it in, okay? You push it in until you no longer hear them air moving at this level, and you pull back by a half a milliliter, okay? That way you know that the cuff is inflated, but it's not rubbing the tube. A lot of people want to do this and say, oh, it's inflated. Well, this doesn't necessarily tell you anything. It's unreliable. So you can either use a pressure gauge if your hospital has one, or you can use listening for the air leak is what you're listening for, okay? When you are changing a tracheostomy tube, which you probably will never have to change one, but you may have to emergently put one in. Let's put a hole in a toilet paper roll for that. Oh, you got a really good toilet paper roll. I need a scissors. Oh, turn off the video.